So, did I tell you about the patient's wife the other day that pissed off everybody on scene?
No.
Yeah.
That's normally you.
So we show up, take him a job. Suitor for restraint of trade. So we show up on scene and the car's there, right? The single firefighter. And we come walking in and the engine had just pulled up as we were getting on the elevator. And the wife of the patient kind of cuts me a weird look.
I mean, are you surprised by you getting a weird look? Or?
Yeah, that's what I was. So anyway, we go in. The guy starts making a report to us. And I mean, he's a paramedic. So this we made him a sepsis alert. He was fairly serious. His pressure was in the 80s. His heart rate was in the 130s.
Yeah.
He just got over treatment for pneumonia like a month ago at the hospital. So we're just getting things rolled in. And I'm trying to talk to the guy. I keep looking up. And the engine company has now showed up. And there's a short redhead female on the engine company that you may know. Well, I don't want to put her name on the podcast.
Oh, no, I wasn't saying that. I was just like, okay.
So, so she comes in. I'm talking to the husband. I look up, and the wife keeps pulling a face at me, just making me like weird looks. I go, is there a problem? Well, you're not in very good shape, are you? I go, I apologize, ma'am. I'll endeavor to do better next time. Right? And she looks at this female firefighter, and she goes, he's not in very good shape. And the female firefighter, thank you if you're ever listening to this, she goes, but he's a very good paramedic. But he's not in very good shape. But he's a very good paramedic, and that's what's important right now.
Nice.
Are you a firefighter? Yes, ma'am, I am. You're too small to be a firefighter.
All right, so she's making friends.
Every single person on that scene when we were leaving were like, lady's a bitch. To the point that when we got to because that was the other thing. They wanted to go to a farther away hospital.
Oh, jeez.
There's like a hospital like 5 minutes away, and they want to go to one in the main city.
Why not?
And so the firefighters had to explain to her why we're going to the closer hospital, and she got all up in his face and everything like that. So yeah, every single one of us were, to the point that when I dropped off the patient in the room and I'm making a report to the nurse, I apologized to her.
Nice. And I'm sorry. This guy seems nice. His wife.
Right.
Yeah.
I'm not convinced how nice he was. He just was deaf and couldn't hear anything anyway.
You know what? At that point, he's the nicest guy out of that household.
Exactly. So. Not a high hurdle to jump. But yeah.
Yeah.
Yeah, you're not in very good shape, are you? I apologize, ma'am. I will never do better next time.
Jesus Christ.
So, hey, welcome to Medical Stuff. My name is Mark Frankham. That could have been a horse also. And that is Chris Finkston over there. How you doing, man?
I'm doing good.
Excellent.
I'm doing good.
Freshie off vacation?
I am. I'm back from Mexico.
I don't think you went to Mexico. I don't believe you, because you are seriously untanned.
I tried to tan. I mean,
we know that you're a pasty white boy.
Legitimately, yeah. So, obviously in this podcast format, you can't see me. Right. And it would be actually hard to look at me due to the amount of reflection.
One word. Translucent.
Yeah, fairly white. I mean, I've met paler people.
But not by much.
Yeah, exactly.
You can literally hold up a light bulb behind Chris.
But yeah, so I went there, and so we had another guy who was with us who burnt fairly easily. He, literally was underneath some sunshade, and he burnt. Jeez. I'm sitting on the beach on a beanbag sprawled out, and I'm only using SPF 30, which, by the way, with the UV index in Mexico, that's pretty much cooking oil.
Right.
And they're like SPF 50s and 70s, and they're like, oh, I'm burning. And I'm sitting there like, burn me. It didn't happen. It's like sun rays come at me, you're like, nah.
Did you have a Lieutenant Dan moment, like in the hurricane, where he's yelling at God to come out?
Yeah.
You're on the beach yelling.
I may have been too intoxicated too.
Or just the right amount intoxicated to do that.
That's true. I will say we were on a yacht doing some snorkeling at one point, and there was a gentleman that was not with us, but he was on the yacht too. And let's just put it this way, the bartender cut him off. If you get cut off by a bartender in Mexico, you are a substantial level of drunk.
I remember a comedian talking about George Bush getting arrested for DUI in 1974. He goes, how blasted do you have to be to get arrested for DUI in 1974 in Texas? He goes, literally this was a time when they just go, look, you drive straight home now, okay? So anyway, tonight we're talking about sepsis.
We are talking about sepsis.
And what is sepsis, Mr. Fangston?
Well, sepsis is when any infection causes a systemic, and by systemic I mean a whole body response that results in at least some level of organ dysfunction. So this is a little bit of a change, and sepsis has recently been making some waves in the medical community because there's been a new consensus on what sepsis is actually defined as.
Ooh.
Yeah.
Sounds like a party.
So sepsis, like I said, it's a systemic response to an infection that has spread.
So when we say systemic response,
It means whole body.
right?
Okay.
So you get pneumonia.
Right.
That is not in and of itself sepsis,
No.
but you can become septic from pneumonia if it starts affecting other systems in your body.
Basically, what it is the bacteria. Well, it's most commonly bacteria, but it could be fungus or viral. We'll be using bacteria as an example for most of this podcast because that is the most common. But basically, what happens is that bacteria gets into your bloodstream, long story short, and goes from the original site, which in this case, in pneumonia would be the lungs, but it could be, for example, also a urinary tract infection, another very common one, and then basically hops on that highway and spreads to the rest of the body. So the systemic response can actually cause a myriad of symptoms. So sepsis actually has, sepsis is more of an all-encompassing concept, but there's a couple other concepts I want to talk about too. One is pre-sepsis, sepsis itself, and then we're going to talk about septic shock.
So would you say that becoming septic is more prevalent now than it has been in the past?
Up until 2016, I would say yes. And the reason I say 2016 is because the definition of true sepsis actually changed quite a bit. And that's actually a good segue right into talking about pre-sepsis and that conversation. So sepsis up until 2016 was defined as a systemic or whole body inflammatory response. In fact, we actually used to call it SIRS, Systemic Inflammatory Response Syndrome.
Right.
And that meant that sepsis included any time that bacteria spread and that you had a systemic inflammatory response. Sepsis has now changed to become, in 2016, it's actually called the Sepsis 3 consensus, is now when organ dysfunction is involved.
Organ? Like the state of Oregon?
Okay. No, organ.
Got it. Okay.
Like the instrument.
Okay, yes, so like a piano.
Very clearly. So if all of a sudden you have a patient that can no longer carry a tune, that's when you know they're septic.
Sir, Doc, will I be able to play piano once I get better?
Yeah. So the symptoms of sepsis are caused when the body has that systemic response and it ends up being harmful. What this inflammatory response can do is it can cause a drop in blood pressure. And this drop in blood pressure prevents nutrients and blood cells and oxygen from getting to organs, which then causes some organ dysfunction. Organ dysfunction causes further drop in blood pressure, which leads us down to septic shock.
So when you have the organ dysfunction, is the continuing down that process, obviously, is that because the organs are then putting off more waste products?
Yes. So, well, you get a couple different things going on. So you have the original organ that is infected.
Right.
So you have like the lungs, for example. And then you have organs that are being affected by the systemic drops in blood pressure.
Okay.
So the initial organ, the problem with it is because there's going to be a systemic drop in blood pressure, your body loses the ability to effectively combat that infection.
Right.
So that infection becomes worse.
Is this also coupled with that infection spreading into those other organs?
Yes, and let me get there.
Okay,
so,
okay.
yeah. So, and then the other problem you have is you do have the ability for the infection to spread to nearby tissues. But the other issue you have is as organs begin to break down due to a lack of blood flow or a lack of nutrients, you'll also get organs putting off waste products, particularly lactic acid can build up.
Right.
And what that will then happen is that can go back into the bloodstream and that can change the pH level of the bloodstream.
Otherwise known as the...
pH is basically what determines if something is acidic or basic.
Right.
Yes, if it's below 7, that's acidic. If it's above, it's alkalotic. Your blood likes to be at 7.35 to 7.45 and doesn't do well any direction outside of that range.
Yeah, this is when I hear people talking about, oh, you want to cure everything that ails you. Drink apple cider vinegar because the acidity will go in and clear stuff. Clean up your blood. Your body,
alkaline diets.
Right. The problem is that your body has to stay within a certain range, and it will do everything it can to stay within that certain range.
And if you're outside of that range, you become very sick.
Right.
Because it affects metabolic processes.
It does. And so you may drink apple cider vinegar, but the point is that doesn't go straight into your veins. Your body breaks that down into what it needs. Mm-hmm. And if your body becomes too acidotic, we'll actually take care of that to balance out. So you're not going to make your blood acidotic by drinking vinegar.
And quite frankly, if you did, you have a problem.
Right.
So if you actually did what it said in the bottle, you got issues.
Right.
So when it comes to the septic process, there is a pre-sepsis phase now. So originally, that used to be just considered sepsis. But in 2016, sepsis is now specifically when organ failure occurs. Well, that kind of kicked off a bit of a conversation in the medical community. What practitioners were worried about is that this was going to cause other practitioners to miss critical patients.
Right.
For example, patients who maybe they have an infection that has clearly spread into the bloodstream and they have other systemic responses, but they don't quite have organ failure yet.
Right.
Now they're not considered septic.
Go home and eat some chicken soup.
Absolutely. Or apple cider vinegar. And,
right.
Yeah.
But yeah, I mean, they're not going to treat it as aggressively because they haven't met that hallmark sign.
So now, exactly. And the problem is with the new definition of sepsis, they now have set criteria for diagnosing sepsis. Right. If patient has A, B, and C, consider them septic. But they now no longer have current diagnostic criteria to define just a systemic inflammatory response.
Right.
The problem with the old method, which is something called it would be SIRS criteria, mentioned it earlier, but systemic inflammatory response syndrome criteria, is that it was too general, which was kind of kicked off the need to redefine sepsis in the first place.
Right.
And what they were doing is they were including too many people into this septic category, and it wasn't really providing a solid route to treatment. Because you had everyone from someone who's clearly not an emergency, but needs antibiotics, to someone who's dying in one all-encompassing umbrella.
Interesting. About the same time in 2016, a lot of your triage cards for the 911 center.
For dispatching.
Gotcha. One of the reasons that you go code 3 to a hospital, or to a patient, to the patient, is because they're either an organ transplant recipient, they're on dialysis,
right,
or they're on immunosuppressant therapy, chemotherapy.
Basically, all three are really good ways to get a nasty infection.
Very quickly.
Yeah.
And so even if you have no other complaints, but you have one of those three, you're going to get a lights and sirens response.
Yeah. And that was the benefit, though, to the 2016 consensus, is it really brought a lot of awareness to the dangers of sepsis itself and organ failure.
And sitting on it too long.
Yeah. The controversy was, though, is it going to create more of this sitting on it too long because now fewer people qualify as sepsis who could easily become septic.
Right.
So that has started the conversation of pre-sepsis and developing a criteria to be able to diagnose pre-sepsis. And they have started that conversation. And one of the things that several providers who are partaking in this controversy have come up with is that there are some ways that you can tell that they believe would be a specific criteria for a pre-sepsis patient.
Okay.
And what they are looking at, let me kind of scroll through here, I will find them.
So while we're waiting, okay, and we're back.
Sorry about that. Okay. So one of the scales I'm going to talk about in a little bit, the new sepsis scale that is replacing SIRS is SOFA, or what we're using in the EMS field is QSOFA, quick SOFA, and we'll get into that in a little bit. But SOFA, basically, a person gets a point for every positive result in this scale they get. For example, a low blood pressure is one of them. That gives them 1 point.
Right.
Okay. A high temperature is another one. That gives them another point. The suggestion right now to determine a pre-sepsis patient is, first of all, either strongly suspected or known infection, either pneumonia, urosepsis, that kind of stuff. A lower score on the QSOFA scale, right now a score of 2 is what we'd consider a sepsis activation. And they were saying if they have a score of 1, and then the next thing would be to be measuring lactate levels in their blood. Because remember, we talked about lactic acid breaking down due to organs having problems. So
and again, in 2016, there was a lot of talk about having lactic level check, being able to check that pre-hospital.
Oh, really?
And the benefit of it. Yeah, they were talking about putting monitors on the ambulances, and some services did, to be able to check it in the field so you could have that. But I think the consensus around here with our short transport times was we're not going to gain much. If we meet it without that, well, it's not like that's going to be the deciding factor, you know.
Yeah.
So yeah, they were actually looking at putting the ability for us to test that in the field on the ambulances, and just for the benefit, the cost wasn't effective.
Yeah, well, exactly, because we have such short transport times.
Yeah.
And quite frankly, and here's the thing, I like to, so in EMS, at least in our agency that Mark and I work with, you really have two choices. You have a code 1 transport, which is no lights, no sirens, and a code 3 transport, which is lights and sirens. For me, I would say, I think both Mark and I probably use code 3 less than I would say the average paramedic. One, we're experienced enough to know that it doesn't save you as much time as you think it does.
Right.
And 2, it's dangerous.
Absolutely.
It can be absolutely dangerous to do, and it can end up causing more harm. So if you're going to use that tool, make sure that the risk and the benefit's worth the risk.
Right.
So, but the reason I bring that up is that the one category where I might be a little bit different is I would consider myself that I probably take more septic-y patients, code 3, than most of my compatriots. And a lot of that just comes from just exposure to several bad sepsis calls. That's just kind of shaped me as a paramedic. But and one of the main reasons that I worry about it, though, is because of the fear of septic shock. So we've talked about sepsis as a whole. We've talked about pre-sepsis. Here's one of the things to know about sepsis. Sepsis is deadly.
Oh, absolutely.
It's a dangerous, dangerous condition. It's considered life-threatening, and it's one of the things that needs to be addressed immediately.
Well, once you tip that balance and you go septic, it's a quick downhill run.
It is a spiral.
You know,
you just go down.
You know, I remember back when I started, you probably heard this also, about patients that are going to be circling the drain.
Yeah.
You know, where they're getting worse, but it takes a little bit of time. Some of your emphysema patients, you've got a little bit of time. Congestive heart failure patients and now really septic patients are the ones that just go straight for the drain.
Yeah.
They'll be hip deep in the drain before you know it.
And actually, sorry, go ahead, Mark.
Well, I mean, if you're not paying attention, they will actively attempt to die on you very quickly.
Yeah. And fun story, sepsis is actually the leading cause of death in the ICU.
Yeah.
Of intensive care unit patients.
Mm-hmm.
And there's a couple of reasons for that. One, a lot of sepsis patients end up in the ICU because they have sepsis.
Right. And
2, hospitals, and I always say this with caution because I worry it's going to drive people away from hospitals.
Right.
When you're sick, please go see your doctor and go to a hospital. But you get a bunch of sick people in one area, one of the things that can happen is disease can spread.
Right. And hospitals work very hard to keep that from happening.
And they're very good at it.
And they're very, very good at it. But life finds a way.
Yeah, and one of the things that we will talk about sooner or later on this podcast is going to be MRSA and other forms of infections that have actually become resistant to treatment over time.
Well, so MRSA is methicillin-resistant Staphylococcus aureus. I believe I pronounced that correct.
I think you did. Basically, it's a bacteria that's resistant to...
Well, methicillin is in the penicillin family. You have penicillin, you have amoxicillin, you have a whole slew of them. Methicillin was at the very top of that for the longest time.
Oh, silly cillins.
But that was the strongest
antibiotic
you could get.
Mm-hmm.
And along comes this strain of this methicillin-resistant bug. And it essentially started in hospitals because one thing that people don't remember, we kind of touched on this during the
allergies episode.
The
I think
allergies
I know where
episode,
yeah,
is that we are over sanitizing our world. And I talk to people about this. I go, okay, look, even if you sanitize an area properly, the way you're supposed to, proper amount of time being exposed to the antiseptic solution, the solution is allowed to sit for the proper amount of time to do its job properly because it's not instantaneous. Even if you do everything correctly, you're still leaving the top 1% of the strongest organisms on the surface.
That's very
because
true.
You can't kill everything.
No.
You know, and so what has happened was through overuse of antibiotics by the general public, and then through leaving the top 1%.
And also consider underusage of antibiotics by a public who maybe doesn't finish their antibiotic dosage.
Right. You're leaving the strongest organisms behind to then mutate into a stronger form of this disease.
Yeah.
Now, the thing about MRSA is you have to be immunosuppressed to get it. If you have a healthy immune system, our immune systems are fantastic.
They're good.
They're very good. In fact, in the service we work for, there's a number of people who, and I'm not bagging on them for this, but we get a patient who's even mildly sick and they all mask up.
Yeah.
I have an immune system, and it works very well. And how it works very well is you get exposed to these diseases, and your body figures out how to beat them.
Yeah.
Now,
I'm not saying go lick a telephone pole.
No,
but
well, splinters if nothing else. But,
right.
But as we go through this process of trying to sanitize everything, we have forgotten that human beings lived for millions of years.
They also die a lot, though.
In a cave. Actually, I was researching this a while back. They say the average age was so much lower back then.
Mm-hmm.
It's not because people didn't live as long. It's because more children died, and it brought down the average.
Oh, damn kids.
So it was very common for children to die in the first 3 to 5 years of life because it was a rough existence. But if you made it to the age of 5, you generally lived a long, healthy life, barring outside forces, a bear killing you or something like that.
But to counter that, though, there is a lot of research and studies that show that with the addition of things like indoor plumbing and sanitation practices, death from disease dropped drastically.
Oh, yes, absolutely.
Drastically.
Well, that's what I'm saying is that...
Huge leaks.
Proper... You do need to have a certain amount of septic technique in your life. You can't just be, pooping in the corner.
And licking telephone poles.
Right. Again, splinters.
All right, fine. I licked telephone poles as a kid, okay?
Nobody's surprised by that.
No.
So, but yeah, if you over-sanitize to the point that you're leaving behind these strongest organisms, then eventually the organisms are going to come back, and they're going to be that much stronger. So this is where you end up with the MRSAs.
Yeah.
And so...
And people die from that shit, too.
Oh, yeah.
So, septic shock, though. So that's kind of how sepsis kills.
Mm-hmm.
That's sort of the final phase as you're going down the drain. And when we say shock, we don't mean like sepsis pops out and scares you and, you do the Scooby-Doo like zoinks and run away.
Right.
That's not the shock we're talking about. Shock in our world basically is underperfusion, which essentially means blood is not getting to the organs it needs to get to.
Right.
So how sepsis causes septic shock is earlier... Mark.
Nope, don't say that.
Okay. Or we're just going to let that sit in there?
Yeah, we're going to say is that I was attempting to make Chris laugh.
And he didn't do anything erotic to the microphone. I think I covered it up good.
Yeah, that's...
I don't think they'll know at all.
You're subtle, my friend. You're subtle.
So, what was I talking about? Septic... Okay, so
I wasn't listening either.
So,
septic shock.
So septic shock, and we just define shock, it's basically blood not getting where it needs to get to.
Right.
And usually this is due to something that's either, Mark and I have done this analogy many times. Your cardiovascular system is a pump, it's a container. The containers are your arteries and veins, and there's a fluid, and that's the blood. You run out of fluid, your blood pressure drops, you're in shock.
Right.
Your tank gets too big, your vasculature dilates for a myriad of reasons. The pressure drops.
That's 2 myriads this episode, just so you know.
Yeah, it's a word I learned. My kids have been watching Sesame Street. I've been picking some stuff up. So, your pressure drops.
Right.
The pump fails to pump correctly, the pressure drops. In the case of sepsis, what can happen is you have this inflammatory response that we talked about. Well, part of inflammatory response is being able to move particular blood cells that attack invaders to different areas of the body. And it does this by making your pipes bigger. The problem is, pipes get too big for too long, blood pressure starts to drop. Additionally, what can happen is when you get an excess of bacteria in your bloodstream, is this also has an effect on your heart's ability to pump very well.
Well, the heart itself can become infected.
Yeah. And so what you end up with is a larger container with a worse pump.
And along with that, you generally have dehydration because the patients aren't bringing in enough fluids.
Mm-hmm.
And so you've actually affected all 3 legs.
And in a lot of areas too, some of the infections can be causing diarrhea.
Right.
or they can cause nausea, which, we're vomiting, and you
Mhm.
lose fluid that way. So yeah, you have all three legs, the pump, the container, and the fluid in it are getting depleted.
Right.
And this is why these patients will suddenly crash.
Mhm.
Here's another thing about septic shock that I really haven't had a conversation about this until I researched it for this episode.
Mhm.
Your body, in response to the inflammatory response, is actually going to try and do an anti-inflammatory response.
Mhm.
Because it will pick up that, hey, the
Right.
container's too big.
Right.
It's not very effective
Right.
because the inflammatory response is just going to overrun it. But it can have an impact on the smaller vessels in your body fairly well. And that would be like, for example, your capillaries or your venules and arterioles. So capillaries are really, really, really small blood vessels that serve the tissues of organs in your skin or wherever the blood needs to get to. That's where the actual exchange of oxygen and nutrients takes place between the cells of your organs and the blood.
Right.
What can happen, though, is these capillaries and venules and arterioles, so those would be these smaller veins and arteries that then feed the capillaries,
Mhm.
they can actually clamp down and clot.
Right.
What can then happen is these clots can then be released. So your septic patient, who also has this larger container with the veins and the arteries, a broken pump, and less fluid, is now also far more prone to stroke and heart attack
Right.
than they were before they were septic.
Well, you were talking about how more people die from sepsis in the ICUs than anywhere else.
Mm-hmm.
And the thing is that even with getting the antibiotics are hard on the body.
Yeah.
They are very hard on the body because you have beneficial bacteria in parts of your body that help regulate diarrhea,
Mm-hmm.
stuff like that. And one of the things that they're doing now is, because there's an infection or a disease called C. diff, which is,
Colostrum difficile.
yes,
Did I say that right?
sure.
Okay.
I just went with C. diff, so I don't think I'm the guy to really go to on that.
Oh, I thought we went which is? You were quizzing me. I'm
No,
like,
no. Which is an extreme form of diarrhea.
Yeah.
To the point that one of the common ways of fixing this, because as you have diarrhea and as you're on antibiotics and you're getting rid of the natural flora in your colon that helps regulate your bowel movements, you are...
Clostridium difficile.
Jeez, you're such an idiot.
Right. I screwed that up.
You did.
People they call us out on the last couple of things we
Right.
pronounced.
Yeah. So, what they've actually started doing are fecal transplants,
Right.
where they will actually take healthy fecal matter, which seems kind of like an oxymoron to me,
Yeah.
and replace it into your colon, hoping to repopulate that flora that you need to regulate your bowel movements.
Yeah, because the C. diff, there's a certain amount of C. diff in there that's fine.
Right.
It's when the C. diff overruns other bacteria
Right.
that you start having a problem.
Mm-hmm. So, septic shock.
So poop.
Exactly.
Anyway, yeah.
So, septic shock, you have the patient the pump is not working as well, the container's too big, or clapping shut and reopening,
Yeah.
and you've clotted, and now you have these clots flowing around, putting more stress on the organs that are not effectively doing their job.
So that should paint a pretty good picture as to why sepsis is bad. Okay. I know you hate that.
I do hate that.
I
But
laugh
anyway,
at that.
So this is why we treat these things aggressively.
Right. And so one of the big parts about being able to treat sepsis is recognize it.
Mm-hmm.
And I'll tell you, in EMS, I always felt that we've been very good about getting in on sepsis, but it seems that lately, I personally have felt there's been a big push on recognize sepsis early and start going in.
Well, I think it fell into before we've always been very good at recognizing, okay, that's sick.
Yeah.
This guy is
Right.
sick. Let's go to the hospital. Let's go really fast, and let's get him there. And now the more the push is, do all that, but recognizing exactly what's going on and initiating treatment. So we talked about one of our first episodes. Really, the push, especially in our area for EMS, has been helping replace that first 10 minutes or replicate the first 10 minutes you get in the ER.
Yeah.
So that when we roll into the emergency rooms, that we've already started down that path.
Yeah.
And so they just pick up they pick up the baton at that point and continue it on. And we're seeing it in multiple areas of our job. But I think that sepsis is definitely one where we're starting to really see that aggressive.
And I think what we've definitely added in there, so it used to be that we didn't have this, but it's now called a sepsis alert.
Mm-hmm.
So we've had things in place for a while to where if you had a major heart attack, we'd call that a STEMI alert. We can get into what that means in a different episode, but that's basically telling the hospital.
I think we did in cardiac.
Yeah, so go check out our cardiac episode.
Absolutely.
But this is something that tells the hospital to get certain steps ready before we get there.
Well, it's a key phrase that kind of catches your ear.
Yeah.
If we say, hey, we're coming in with a chest pain patient and blah, 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 and we think they're having a heart attack, they've got three things going on a lot of times. When they're on the radio, they've got people talking to them. Whereas if they hear the term STEMI, then that makes an automatic trigger for things are going to happen.
They get a cardiologist ready. They get some interventional stuff ready.
They'll call the cath lab and let them know they need to start getting set up.
And then we had the same thing for strokes.
Yep.
And now sepsis.
Mm-hmm.
So sepsis has kind of joined those rankings of this is really bad. We need to have things ready to go the moment you roll in.
Not roll in. Because we come in before code 3, and then the nurse would come in and the doctor would come in, they would start their assessment.
Right.
Whereas now we're rolling in the door and they already have things preset.
Yeah.
So that they, like I said, they can take over and continue on up the path. So along with STEMI alert, stroke alert, and sepsis alert, my push for the next big one, I think this is going to take off. It's going to be a triage alert.
I thought you were going to say awesome paramedic alert.
No. But a triage alert. And these are for those patients that really don't need to go to the hospital by ambulance. And they can go to the triage area.
I feel I was right with awesome paramedic alert.
Yeah, but you always do.
That's true.
That is very true.
So the big part of getting sepsis right, though, is recognizing it in the first place.
Right. So
here's kind of the steps we go through to recognize a septic patient. So the biggest thing I would say is going to be history.
Right.
History is an important step. You don't want that to stand on its own. There are some other clinical findings.
No, but if you have a patient that's prone to UTIs, and a UTI is a urinary tract infection.
Yeah.
And you'll come across patients that get them regularly.
Oh, yeah.
Patients that have had pneumonia in the past are susceptible to pneumonia in the future.
Absolutely.
And in a more aggressive ability, because their body already knows they can't fight it, and you will actually really run into problems with that. So, yeah, go ahead.
Oh, yeah. So, because like we mentioned earlier, sepsis is an initial infection somewhere else that then spreads. So the detective kind of has to kick on in the paramedic and figure out, is there a chance for an initial infection? And that's why the history is so important. So a lot of times, I'll start by looking for a septic patient by looking for signs and symptoms of common infections, such as UTIs and pneumonia. Has the patient had a cough lately? Mm-hmm. Have they had a fever? Are they currently taking antibiotics? That's a huge clue.
Our patient the other day had 3 weeks ago got released from the hospital for pneumonia.
Yeah, absolutely.
Very strong smelling urine. With that smell, you've been there. You walk in, you're like, oh, they smell like a UTI.
Yep. You can smell the urine when you walk in. It's discolored urine.
Yeah, very cloudy.
Yeah.
Just a very strong, not ammonia smell, but just a very strong urine smell, a concentrated urine smell.
Yeah. So then after we kind of establish a history, like once we think that there's a possibility that there is an infection that could be kicking off this sepsis, we then start looking to see, is this infection possibly made this person septic? So I do kind of want to go over the previous SIRS scale, because to me it is an important scale.
Right.
And it's definitely something that a lot of providers still have a little bit of controversy of whether or not we should still be using it or not. So that's SIRS, and I mentioned it before, but Systemic Inflammatory Response Syndrome. You get a point for each category. So what we would look for in the field, now you got to remember though, these two scales I'm talking about, there's quick versions for paramedics in the field where we don't have access to a lab, and then there's much, much, much longer versions when you get into the hospital.
Where they can check lactate and they can check.
Yeah, absolutely. Well, like for example, the SOFA scale, which we'll talk about in a little bit, the hospital version, it's about a page of just criteria. We're not going to touch on that on this episode. No. That'd be a lot, but that could be its own episode. So, the SIRS score. So the first thing that we can look for in the field, provided we have a thermometer, is a temperature that's greater than 100.4 or less than 96.8. Now, one of the things you might be wondering is if I have an infection, a common response is a fever. That's actually a response from the body to bring up the temperature, which makes it hard for bacteria to survive. That's why you have fevers, by the way.
Right, to kill those bacteria.
Yeah, and so you might be saying, but why less than 96.8? Why decrease? Like, why would the body decrease? Well, we talked about septic shock earlier. And one of the ways that heat transmits very well through your body, and actually very well in physics, is through fluid. And so when we stop bringing that fluid to the surface due to a decrease in blood pressure, you can actually have someone's skin become cooler.
Well, these are patients that when you're sick and you get the hot flashes followed by the chills.
Right.
It's because your body, as it raises its own internal temperature to fight the infection, will also subsequently work to shut off that extra heat to keep you from getting too hot.
Yeah.
And once that happens a little too effectively and you're sweating and you're doing all that kind of stuff,
then your blood pressure drops.
Your blood pressure drops. But even if you're not to that point, you're sweating, your body's flush all over, you're venting off that heat, you can't go back too far the other way and you get the chills.
Yeah. So that's why that's one of the criteria we look at. Other than that, heart rate greater than 90, respiratory rate greater than 20.
And we say heart rate greater than 90 because these people are generally sitting still in a chair.
Right.
And so they shouldn't have a fast heart rate.
They really shouldn't.
Unless their body's working at something like, I don't know, off the top of my head, fighting an infection.
Yay. Good one, Mark. And a respiratory rate greater than 20 for the same reason. This is a patient sitting in a chair. They're working at fighting off an infection. That's going to require more oxygen. It's also going to require us to exhale more waste. So we have to breathe faster. And the other thing, and we wouldn't do this in the field, but we do draw labs in the field.
We do.
Blood labs is a look at white blood cell counts. So they want to look at anything greater than 12,000 white blood cells per microliter, or less than 4,000 white blood cells per microliter. Greater because if you're at the beginning of an infection, you're going to have a substantial, your body's going to increase the amount of the white blood cell production to fight the infection.
Yep, your immune system's going to kick into high gear.
However, as white blood cells are made and destroyed, and your body can no longer produce at a rate to fight the infection, your white blood cell count will drop.
Well, especially as the infection takes more hold,
yeah,
it's going to drop because as your body loses its ability to produce white blood cells, they're still dying.
Yeah.
And so you're going to drop off because the infection's killing it off faster than your body can produce them.
So in a patient with a history of infection and a low white blood cell count, that's a bad sign. They're losing the fight. So that was the older scale. We really don't use that one anymore because it had a couple problems. And one of the problems we almost kind of alluded to, we said, okay, a heart rate greater than 90, a respiratory rate greater than 20. For a patient sitting in a chair, that should be abnormal. The problem is there's a lot of things outside of infection that can cause a heart rate greater than 90 and a respiratory rate greater than 20. Being nervous can cause that.
6 medics staying in your bedroom.
Absolutely. 6 handsome medics.
So you're not on scene.
Yeah, no, I'm not there.
Okay.
Yeah. So I'm supervising. I'm in the office watching the call on the screen. Anyway, so right, and so that was kind of that's why the SIR system drew a little bit of fire, and that kind of motivated to have a new consensus of what is sepsis. So what we're using now in the field is QSOFA, or Quick Sepsis-Related Organ Failure Assessment score. And what we're looking now is this is a score that is more concentrated on looking for organ failure. Because remember, that is the new definition, is organ failure, not just systemic.
New hip definition.
Yeah. And one of the first category there is a systolic blood pressure. That's the higher number of your blood pressure. If you have 120 over 80, the 120 is systolic, of less than 100. Respiratory rate of greater than 22, and a Glasgow Coma score less than 15.
So Glasgow Coma Scale, we've never really gone over this before.
Yeah, so we'll kind of touch on it here, and there'll be another episode. I want to do an episode on head trauma, and that's where something we'll talk about. But a Glasgow Coma score is yet another scale that we use to determine someone's cognitive function. Okay, and so it's divided into 3 categories. We look at what are their eyes doing, what are they doing verbally, and then motor skills as well.
So under the eyes,
you have
you have your max points for all 3 categories are 15.
Yeah, the 15 is a perfect score.
Right.
And it's
the least number you can score is 3.
Right.
The way I was explained to me was You got 3 just for showing up.
Yeah, exactly. What was always said to me was that your textbook has a GCS of 3 right now.
Right, because it's here right now.
Right.
So if you're so you have eyes, like Chris said, you have verbal response, you have motor response. If you have no response to any of those, you have a 3.
Right.
So your eyes have a max point score of 4.
Yeah.
So you sitting around with your eyes open talking like Chris right now is a 4.
We can consider that spontaneous eye movement.
You walk in a room and somebody's sitting there looking around, that's it.
Yeah.
Now, if you walk in and somebody's sitting in a chair and their eyes are closed and you go, hey, man, and they open their eyes, that's a 3.
Yeah. That's called a response to verbal.
Right. Mm-hmm. So then if you have to provide noxious stimuli, and there's different ways of doing that.
One way is to rub the sternum really hard.
With a knuckle.
Yeah, that hurts, by the way.
It does. Sometimes it's a push on the cuticle.
Punching them in the face?
Right. Well, that generates different paperwork.
Wait, no, that's not?
Yeah, it is noxious, trust me. It's not, so you score them on a scale of 1 to 4 in that section. Then your verbal is, the top score is a 5.
Right.
And that is a person who is alert to person, or a time, place, and person. So that means they know what's going on around them. They understand the situation.
They're giving appropriate responses to questions as well.
Then you have the patients who are confused.
Right. And confused patients might be patients who keep repeating themselves.
Right.
So the questions and responses are appropriate, but they can't really figure out what's going on. They can't remember things.
Right. You ask somebody, hey, what day is it? Wednesday. Well, okay, it's Friday.
Yeah.
So that person will be confused. After that, you get a patient who is using inappropriate words. Hey, what day is it?
Salad.
Rutabaga. Yeah.
Oh, you said rutabaga?
Rutabaga.
Oh, gosh. Rutabaga is better.
Yeah.
That's a good example.
So then you go from that to 2 points is incomprehensible sounds. Or just
screaming.
Whatever. Yeah, exactly.
Yeah.
You're not making any sense. And then, of course, no response for 1. Under motor, you have a 6-point scale.
Yeah.
So you have obeys commands. So we're going to take your blood pressure. Is that okay? Can you stick your arm out for me? They do that.
Obey the command.
Moves to localize pain.
So if I start an IV and they suddenly kind of pull away from that IV,
but they're not following commands,
that would be 1 point off.
That'd be a 5. Flexion, withdrawal from pain. So when you start the IV, they actually pull away from you.
Yeah.
Abnormal flexion, decorticate is 3, which decorticate is where the arms are actually turned in towards the center of the body.
Yeah, it's not necessarily in a response to, for example, it's not like localizing the pain.
Right.
There's nothing. It's just you'll see their arms curling.
Generally, like Chris was talking about, associated with a head injury or a head trauma,
right,
or something going on inside the brain. Then you have discerebit flexion, which is where your arms are actually flexing away from the body, out to the sides, and then no response. And so this is something that we use to determine the patient's mental status and level of consciousness.
And so in the SOFA scale, they get a point in the SOFA scale if any of those things loses even 1 point.
Right.
That's a point in the SOFA scale. So you can see the SOFA scale is geared toward the signs and symptoms, or the signs that we're looking for in the SOFA scale are a little more severe. Lower blood pressure, even higher respiratory rate, and an altered mental status. Because that one is looking for organ failure.
Right.
So those are the criteria that we now use to do that sepsis activation that we just talked about.
Right.
And so for us, if they have a known or we strongly suspect an infection, and they have 2 or more of the SOFA criteria that we just mentioned, that's a sepsis alert. Mm-hmm. Now, of course, here's the thing as a paramedic. If I'm a paramedic and I'm there, it's like, all right, they have a definite infection, their blood pressure is low, but technically the respiratory rate isn't above 22, and they're technically alert and oriented.
But they've got a fever?
I'm going to call that a sepsis alert. Mm-hmm. And here's why. Do I technically fit the protocol book there?
No.
No. But I've been around the block enough to know that, you know what, maybe they don't hit the SOFA criteria right now. Give them a few.
Well, and the thing is that, especially as a paramedic, we're given a little bit of leeway, or a decent amount of leeway, for paramedic discretion. No, this guy doesn't fit the protocol exactly, but they want us to use our best judgment. Our guy the other day, his pressure was in the 80s. His respiratory rate was probably 20, and he wasn't necessarily, he was a little bit confused, but it was hard to tell if that was because he was confused or if because he was having a hard time hearing us.
That's true.
Right? So, borderline. Temperature's 103. That's a sepsis alert.
Yeah.
And his heart rate was above 120.
Yeah.
We're going to call this a sepsis alert. And we roll into the hospital. We went straight into a room, and the nurses were in there. Before we left, they had 12 people in that room jumping all over this guy.
Yeah, and they should.
And they should.
Yeah.
Because he's going to go, and he's going to go quickly.
Well, I had a guy today who we were called to a clinic.
Mm-hmm.
And we arrived at the clinic because the clinic was concerned that he's been battling a urinary tract infection for the past 7 days. And he's been on an antibiotic for it.
Mm-hmm.
And he came in today. Doc says, yeah, his temp is 103.
Right.
Now, here's the thing. I did not take him code 3. His proximity to the hospital was 7 minutes, code 1.
Right.
And he met none of the other QSOFA criteria.
Right.
On the way up to the hospital, he started to pant a little bit, and his respiratory rate got to 28, so he met that.
Right.
But in that case, it was one of those things where this guy needs to go to the hospital. The clinic was absolutely right, being like, don't go home.
Right.
But would the lights and sirens have benefited this gentleman? No.
No. Probably not.
And the main reason being is because our proximity to the hospital was very, very short. His blood pressure was very stable. He wasn't altered. His respiratory rate initially counted it at 20, came up to 28 at one point. And my rarity report was very solid.
Mm-hmm.
And I told him exactly what was going on. He has urinary tract infection that he's been fighting. He is taking an antibiotic. However, his temperature is 103.
Right.
And I very specifically said he doesn't, and at the time I gave the report, his respiratory rate was 20.
Mm-hmm.
He currently does not meet any QSOFA criteria, so I'm not making this a sepsis alert. Our ETA to your hospital, 7 minutes. So here's the thing. They know what I know enough.
Right.
They know, and I think they gave him a little bit of confidence of, okay, this medic has looked at the QSOFA criteria.
Right.
He's making considerations here.
You're making logical decisions.
Yeah. So in that case, code 1 was totally appropriate for this guy. I will tell you, though, if his blood pressure even got near that line, or quite frankly, even if I noticed a drop that maybe wasn't below the 100 line, but was substantially down from the 120 he started at, probably light him up.
Oh, yeah.
Yeah. So once we've identified sepsis, how do we treat it?
Go fast.
Yes. Yeah. So we have a joke in paramedicine.
Sure.
Yeah. Yeah, why not? We have a joke in the paramedic industry, and that is called treat with diesel.
Mm-hmm.
And that's basically, they're all diesel engine ambulances. Not all of them, but most of them are diesel engine ambulances. Right. And that needs to give some more diesel in there.
Oh.
The other thing, no, you don't give the patients diesel.
I need to go rewrite some charts real quick. I'll be back.
There's some paperwork. Prescribed by Dr. Texaco. All right. Anyway, so one of the things that we're going to do in the field, though, we're going to be supporting vital signs. So if we see a blood pressure that's dropping, we're going to want to treat that with fluid. And we talked about that whole pump system earlier. So we're just going to be adding fluid to that container pump.
To keep the blood pressure up.
Yeah, because we talked about those 3 legs. All 3 are infected. We're going to help one of those. If the blood pressure continues to drop, or if we start off and it's really low, we can actually give what's called vasopressors.
Well, also the thing to think about is if we start giving fluid,
Mm-hmm.
we can give too much fluid.
Yes, you can.
And so we need to make sure that we're not diluting the blood to the point where even if it was a good blood pressure, that you still couldn't support life.
And then
real quick, I'm sorry.
But, go ahead. You're fine.
Or you overload an already sick heart.
You're okay, Mark.
I know.
Yeah.
But you overload an already sick heart and you cause the patient to go into congestive heart failure.
This is what we mentioned earlier, because the heart's not pumping the way it should.
Mm-hmm.
So when the heart can't pump the way it should, if you listen to our cardiac episode, one of the things the heart has to do is pump blood to the rest of the body. Well, before it does that, that blood comes back from the lungs. Well, if the heart's not doing a good job at pumping the oxygenated blood out of itself to the rest of the body, it's going to back up into the lungs. Mm-hmm. And now you've got that on top of everything else. So one of the other things we can do is we can give a drug called norepinephrine. Norepinephrine does a couple things for us. One of the things it does is it shrinks the size of the vasculature, your veins and arteries. Mm-hmm. So that takes that container we were talking about, makes it smaller, helps bring up the pressure. It also helps the contractility of the heart muscle. Your heart will start beating a bit better.
So norepinephrine is part of what makes up adrenaline.
Yeah, that naturally occurs in your body.
Right. So you hear... So yeah, it's not only will it help you survive the sepsis problem, but it may help you lift a car off a baby.
Absolutely. The way it works in your body is there's actually a bunch of little paramedics with syringes, and they just sit there and push them into you.
No, so yeah, the norepinephrine will increase the heart's ability to contract so that it's pumping blood harder.
Absolutely. And what we want to do is we want to get that blood. We talked about shock earlier.
Mm-hmm.
We want to prevent that shock. We want to get that blood back to the tissues that it needs to feed.
Right.
And that's the whole goal there. But the problem with all this is while it's good to do in the field and it can get a person alive to the hospital, ultimately that infection has to be addressed.
Right.
That's what's causing all this. The body is not able to address it on its own. That's why we're here. So pretty much what will happen right off the bat, if we make this sepsis alert, they're going to go into the emergency room. Very first thing that's going to happen is they're going to get what we call broad spectrum antibiotics. A broad spectrum antibiotic is basically an antibiotic that's going to impact a lot of different infections out there.
Because everybody thinks of an antibiotic as you take it and it fights infection.
Yeah.
And it does, but there's a reason why you get one type of infection and your doctor puts you on a penicillin based.
Yeah.
And then you get a different type of infection. You get like a tetracycline
Right.
type medication, which is a different type of antibiotic. They fight different things better.
Yeah. So what they start off is giving you one that generally fights most things well enough.
Right.
And
Yeah. And they go with this because they don't really know what kind of infection it is. We just need to fix something.
Yeah.
A number of years ago, I don't know if you remember, I ended up in the hospital being septic.
Yes. No.
Yeah.
I don't remember you being septic.
Yeah. I spent like 3 days.
Oh, damn.
Up there. And so I'm laying there in the middle of the night. I've been there all day. First of all, the ER doctor comes in. He goes, well, I think we're going to send you home. Your pressure looks good. It's like 112. I'm like, Doc, I haven't had a pressure of 112 since I was 13. So, plus, because of a medical condition I have, which is called psoriasis,
mm-hmm.
I'm on an immunosuppressant. Right?
Yeah.
So he called my primary care physician. My primary care physician's like, so maybe we need to keep him for observation? I mean,
Yeah.
He is on an immunosuppressant. I'm laying there in the bed in the middle of the night. Nurse comes in, wakes me up. Where's your IV? I stick my arm out. And I go, what are we doing? He goes, well, we're hanging some vancomycin. And I pull my arm back. Vancomycin is what they give you. It's top shelf stuff.
Yeah.
This is, they're working to come up with something better than vancomycin if they haven't already. But right now, it is the go-to when nothing else is working.
It's the Don Julio 1942 of the antibiotic world.
Wow. That is an odd way of putting that, but I see where you're going with it.
Yeah, hey, Don Julio, it's some good stuff.
Right. So,
that guy that just
and I wasn't against getting the vancomycin. I just went, why are we going top shelf?
Right.
What last I heard, basically during the course of the evening, and into the night, my pressure kept going down.
That sucks.
So he goes, well, so I said, why are we going with vancomycin? Well, the doctor ordered it. Well, no shit, Sherlock. I didn't think you're just freelancing out there. I said, well, why did the doctor write the order for it? Well, the doctor can come in and talk to you about it. Yeah, I'd like that.
Yeah. So
the doctor comes in, and he's like, is there a problem? I go, it's not really a problem.
Yeah.
I just know that vancomycin is not your run-of-the-mill antibiotic. I said, so why are we going top shelf? Oh, well, you're going septic. No, there was more to it. You're going septic, and we don't know what's causing it. And I don't want to give it something that's just going to piss it off, so yeah, we're going to go nuclear on it. Okay. I'm good with that answer,
Fair enough.
Basically, they had no idea why I was going septic. So they're going to go with the stuff that is the big guns just to make sure they took care of whatever it was.
Yeah. There you go.
I'm down.
So, a lot of times, after they do that, after they bring out the big guns, what they'll do is that is something they want to get started while they do particularly blood work. And they're going to find out what kind of infection do you have. And then what they may do is hone it down to an antibiotic that fights that particular infection better than the big guns.
There's antibiotics that fight UTIs better than they fight pneumonia.
And one of the things that can happen too is if it's a severe enough infection, you may go home on long-term antibiotics. It can be an antibiotic course that's up to 90 days. Some are up to 6 months.
Some patients go home with what's called a PICC line in place because they're going to receive IV antibiotics over a long period of time.
Yeah, and what they're trying to do, and these are patients who not only had a severe infection, because that's one of the things to remember too, is this typically bacteria that's gone from one infection site to the rest of the body is going to find a way to hole up in other places too. And so just eliminating, just clearing up the pneumonia, for example,
Right.
might not do the trick. So these are people that are going to be prone to a reinfection
Right.
due to the amount of a severe infection that they had. So they will stay on long-term antibiotics even if there's no sign of the infection.
Right.
So with that, yeah, that's about it. Once you get that primary infection out of there,
Yeah.
it's pretty much recovery from there.
Yeah. And, like we said, once you get this infection once, because of that, there's always going to be a little bit of the infection left.
Yeah.
You are prone to this infection. So it may not be while you're healthy. If you're running around, everything's going good, you're living your normal life, your body will be able to fight it, keep it at bay.
Yeah.
But if you get sick on something else or you have severe trauma and your body becomes immunosuppressed, that's when these bacteria or these infections will become aggressive again.
Yeah. And so these infections typically impact, like Mark said, the immunosuppressed, the very young, who don't have much of an immune system built up, or the very old,
Right.
Who are just generally more fragile.
Right.
However, it can happen to anyone.
Absolutely.
And it does happen to anyone. And that's kind of one of the things they've also been stressing in terms of public information.
Just because it's a young 25-year-old guy doesn't mean he can't get septic.
I do want to share one story before we close this off, though.
Okay.
One of my favorite calls. So every now and then a paramedic might say this. I've heard a few people say it. They have their Dr. House moment.
Yeah.
If you've ever watched the show Dr. House, he basically, the whole goal of the show is that he comes up with these diagnoses that no one else can get to. Or that no one else sees. And he's a genius. And we had a call which, in retrospective, it was probably more obvious than it should have been.
Right.
But we all got in there, and it was a younger guy in his 30s. And at first we're thinking this must be an overdose. The guy is acting bizarre. We got a 911 call for someone acting bizarre. When we get in there, he's laying on the ground moaning. Not doing much of anything. Can't really get effect. So his GCS, eyes to pain. So that'd give him a 2 there. Verbal was incomprehensible, so he gets a 2 there. And then motor would probably be localized pain, so that would give him a 5 there. Okay, so that puts him at a 9.
Mm-hmm.
It's not a good GCS.
No.
Okay, considering 8 is like, hey, we need to intubate this guy. Intubating is putting a breathing tube in somebody.
Really, anybody not 15 is not good, but anybody below 13 is really starting to have some problems.
Yeah. And so we're trying to figure out what's going on with this guy. The only medication that we believe he has access to is Seroquel. And Seroquel, you can overdose on. It can cause some symptoms. But this guy, he has a heart rate of about 120, laying on the ground. And we initially thought what we saw was poop all over the place. And his room, it's a hotel he's staying in, looked ransacked. And so we're like, okay, this is really bizarre. And this is where I knew I'd arrived at a paramedic. Because I look around, I'm like, that over there is poop. This is dried blood. And when you can tell dried blood brown from poop brown...
You've been around the block once or twice.
Exactly. And so then one of the other paramedics who had been there for a while, he's one of the smaller towns nearby, but he'd been doing it for a while. He goes, you know what? You're right. Where's he bleeding from?
Right.
So now we start taking this guy's clothes off. Yeah. With the amount of poop and blood, though, not that sexy. Yeah. And we find a wound on his leg with an old bandage. Start to peel the bandage back a little bit.
Bad choice.
Yeah, well, not enough to open anything up, but just enough to be like, what's the skin look like? Start peeling it back.
The smell.
Well, the whole place smelled terrible anyway because of all the poop.
Yeah.
So, which, by the way, to mask a smell, I'm going to recommend a Glade plug-in, not poop. But in this case, it might have been helpful to avoid rotting flesh.
Right.
And by the way, that's another thing that paramedics have. A lot of people think the worst smell... No. Well, it depends. How old are they? Anyway, so a lot of people think the poop is the worst smell in the world.
No.
Nope.
No.
Rotting flesh.
Rotting flesh. Burnt skin.
Burnt skin is really bad.
GI bleed.
Yes, because that's a good mixture of poop and blood
and being digested.
Yeah, it's not fantastic. Anyway.
Has nothing to do with sepsis. Moving on.
So sure enough, we look down and we see a nasty, nasty wound.
Mm-hmm.
Sepsis. And so it was kind of that moment of looking around the room, recognizing 2 different types of browns.
Right.
He's bleeding, check it out. And that was my Dr. House moment.
Right.
All of a sudden, whooking. And back then, so we started dumping fluids in, we didn't get a response. We got about 1.5 liters in. And then we switched over to, at the time we used dopamine instead of norepinephrine. And so we switched
Why
over.
did we go away from dopamine?
because dopamine pretty much turns into norepinephrine anyway.
Your body metabolizes it into norepinephrine and goes from there.
So we might as well just start with norepi. So we gave dopamine at the time. And it was actually interesting because the physician that we called to the hospital we were going to, on the way, well, we didn't call him, we just gave a report. Mm-hmm. Nurse told the physician, she came over, physician wants you to stop the dopamine immediately. I'm like, okay. And we get in there, it's like, what was that? He goes, oh, no, dopamine. It starts listing side effects, and he's really scared of it. Gets in there, pressure starts dropping. Guess what they turned back on?
Dopamine?
Dopamine.
Yeah.
Yeah. Anyway. So that was my little Dr. House moment, and it was a sepsis patient. But other than that, Mark, I ain't got not much else to say on sepsis.
No, I think we can close this one down and call it good.
Yeah.
So, Chris, have a wonderful day.
Mark, have an okay evening.
So, this is Medical Stuff. If you want to find us on the interwebs, you can go to medicalstuff@facebook.com.
Yep.
You can also find us on Twitter at Medical Stuff or at Medside Stuff. Or you can email us at medsidestuff@yahoo.com. We're also on Instagram.
And don't forget to check us out on iTunes and Google Play. Also, check out our YouTube channel and subscribe. If you subscribe, then you get the episode sent to you in a notification the moment it goes up.
Yep.
Alrighty. So with that...
toast. Shut it down.
All right. Adios.
Accept it that way.
I don't know. Where's the button? Got it.